Dr. Paulett?
Yes.
Please begin. Thank you.
Okay. Thank you. It's 1 o'clock and we'll get started. Good afternoon, everyone. I'm Aaron Paulett, the Provincial Head for Pathology and Laboratory Medicine at Cancer Care Ontario. On behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP Checklist Education session on melanoma. Before I introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. This session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. Both the live presentation and the recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note the CME certificates for each of the CAP Checklist education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot WebEx issues as part of this call. If you're experiencing technical difficulties, please call the WebEx support line. We encourage you to submit questions at any time during the presentation using the chat feature within WebEx. Chat instructions can be found in the session notice. During the question and answer portion of the presentation, a session moderator will pose the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institution, the name of the individual posing the question, and the question itself. It is now my pleasure to introduce Dr. David Shum. Dr. David Shum obtained his bachelor's degree in medicine from the University of Hong Kong in 1975. He completed his anatomic pathology residency and dermatopathology fellowship at the Western University in London. He was an associate professor in pathology with cross-appointment in dermatology at the Western University and head of surgical pathology at the University and Victoria Hospitals in London before practicing at the Vancouver General Hospital and St. Thomas Hospital. He is the past Cancer Care Ontario Erie St. Clair Regional Clinical Pathology Lead and past president of the Ontario Pathologists Association. Dr. Shum is the current chief of the Department of Pathology and Laboratory Medicine at the Windsor Regional Hospital. He is an adjunct professor with the Pathology Department, the Schulich School of Medicine at Western University, and an adjunct assistant professor with the Physics Department at the University of Windsor. Dr. Shum has been the dermatopathologist at the Medical Laboratory of Windsor and consultant dermatopathologist for Southwestern Ontario since 1989. His publications include an atlas of histopathological features in common skin diseases, and his current research interest is focused on the use of ultrasound microscope in diagnosing skin tumors. Without further ado, I give you Dr. Shum to give today's talk on melanoma.
Thank you very much, Dr. Paulett, for the kind introduction. I'd like to add my welcome to everybody. Good afternoon. I want to just take this time to also thank Dr. Strigley for his invitation and for the partnership to sponsor this educational session. Just delighted to be here and do the review. I just want to apologize on behalf of the hospital, my hospital IT department, as they were unable to open a little portal in the hospital firewall to allow the WebEx in, so I will have to give verbal clues to advance the slides and hope it's not going to interrupt the flow of the talk too much. But we should get started, and the next slide will show that I have no interest or conflict of interest to declare. The next slide will show the objective of this webinar, which is to review the latest College of American Pathologists here on this CAP, cutaneous melanoma protocol, and the posting date was January 2016, version 3.4.0.0. So it's really a very new protocol. I personally used in the hospital a third-party middleware, so it has not been changed. So it's all on paper, and I've not used this yet. But in this new protocol, the newest protocol, there is the inclusion of biomarkers template, which the Cancer Care Ontario would like to see it used now, as in April. I want to give a bit of historical perspective. The next slide will show that, and we know the CAP checklists, which are now reporting standards, are actually based on the cancer staging manual, and we know that this foundational document dates back to 1977 when there was the first edition. In the case of melanoma, of course, at the time we started to learn about histopathology, the growth phase, the POX level, the breast flows, and as our knowledge increases with the correlational studies, we recognize the importance of LVI, satellites, ulcer, and dermal metastatic activity, and that's prompted really substantial updates in the 5th, 6th, and the 7th edition. And our current latest checklist is based still on that 7th edition. I should also point out that in 1977, that was the year that Dr. Fred Sanger of Sanger sequencing fame reported the sequencing of DNA nucleotides, for which he got his second Nobel Prize in 1980. And so, concurrent with our understanding of the histopathological features, we also, with advent of the molecular technology, starting to crack the molecular codes and start to understand the molecular basis in oncogenesis. 2002, BRAF was reported as a significant and frequent mutation in cutaneous melanoma. And only 9 years later, we have the BRAF inhibitor that actually works well in patients with metastatic melanoma. So really a significant progress, and it's apropos now that in our latest cutaneous protocol checklist that we are combining a molecular biomarkers template in our report. So hope I'm not digressing too much, but we should go back to the protocol in my next slide. We'll show that there is really welcomed addition to our current protocol that's in use. That is, we now have a standalone biopsy case summary. And I'm sure by the omission of some of the mandatory entries in the long form designed for multi-use for biopsy, accession, and re-accession, we should be able to increase the submission rates as scored by Cancer Care Ontario. So we're going to have a quick look at the biopsy case summary. And of course, we're going to have a look-see at the ancillary studies, i.e. the biomarkers. And there are other minor modifications as indicated on my slides that we're going to go through. Next slide will show the new biopsy case summary that is on the left side of my slide versus the long form, which is designed for excision and re-excision. I'm sure we're all familiar with now the plus sign, which I highlighted, and the plus sign means that it's really not a mandatory entry. So right off the bat, we see that for the biopsy case summary, we really don't need to enter in the tumor size. And this is really appropriate in the sense that those of us, especially working in the community, we don't really get a lot of clinical history with skin biopsies. Commonest diagnosis that I see is lesion, and the next commonest is probably rash. So sometimes it's just difficult to gauge the clinical size or the tumor size, and often enough, the submitting clinicians really have no idea that it's going to be a melanoma, and so it helps with the entry and use of the synoptic report. Microsatellite is another entry that is going to be omitted in the biopsy case summary, and we'll talk more about the microsatellites later. So moving on to the next slide, you can see a column of plus signs over the distance, the marginal distance over the biopsy side. And again, that's very helpful in measuring size of margins in biopsy samples is really kind of irrelevant in melanoma, as any biopsy diagnosis of melanoma usually is followed with a wider excision. And whereas for the re-excision, the long form, then the entry of the measurement is required. The little red stars basically highlights the additional comments that are included in the newest 3.4 version. Again, we'll look at more of these comments as we go with the long case summary for excision and re-excision. Of note too, there is a deletion of previous comment, quote, required for excision specimens only. So basically, they're replacing the new comment applicable to invasive tumor only, and use that instead of required for excision specimens only, and that's all. So let's move on. Next slide. Again, not required for the biopsy case summary is the entry for microsatellite. As we know, microsatellite is really a feature of pretty advanced melanoma that measures usually over 1.5 millimeter, and it's not easily identifiable at times in the biopsy. So it is indeed a welcome change, and to expedite and the use of the biopsy case summary, as in contrast to the long form for the excision and re-excision, microsatellite ptosis is a required entry, but with a new comment. Again, the same comments, and you'll find get repetitive, but added to basically titles and headings that describe invasive melanoma. So it's really kind of stating the obvious as we look at it more. Also not included is the TIL, or inflammatory host response, or tumor-infiltrating lymphocytes. We know that TIL really doesn't have a high p-value when it and not a good prognostic indicator, so it's dropped in the biopsy case summary. And basically, the biopsy case summary is going to end with the PT staging. Nothing is changed for the PT staging, of course. And then additional pathological findings as well as ancillary studies are not mandatory with the plus signs. Whereas for the long forms, it will go on to the PN and the PM and additional entries, which we're going to look at right now. So the next slides will show the long excision and re-excision case summary. Still a multi-use protocol, but with removal of the biopsy samples out, I think the flow and the use, and you'll find the use of the protocol a bit easier. So going through it, the procedure, nothing's changed there, the usual, and we've been using this form for a couple of years now. So excision, re-excision included, and the lymph nodes. And the stop sign, the little cross-check signs basically reminded us that tumor size, microsatellites are not required for the biopsy side. And you see the red starburst that indicated the new comment, i.e. the applicable to invasive tumor only. And you see that repeatedly, as I mentioned, in headings for invasive melanoma. So I'm not going to dwell on it further. And also omitted in both the biopsy case summary as well as the long excision re-excision case summary is the dropping of the macroscopic pigmentation, which is no longer required. And that should really not make any impact as to the significance of prognosis when it comes to prognosis as pigmentation. I know previously we thought about amelanotic melanoma as perhaps a slightly more aggressive lesion, but CAP thinks we can drop it. And it is also not an easy entry because many a times we are dependent on the clinicians for this piece of information. So carrying on in our next slide is the histological type. Added in this 3.4 version is the no residual melanoma, which really caters to the form being used for re-excision sample. That could create some problem, and I'm going to get back to it. Also new in this latest case summary is the addition of the melanoma in situ segment. So basically, CAP included all variants of in situ melanoma, and these are WHO classifications, so I'm sure we are all familiar with it. I just want to comment on persistent melanoma. It's really a term that I use for recurrent melanoma, rightly or wrongly. And so I find it certainly a bit more frequent than, say, melanoma arising from blue nevus or melanoma of childhood, but it's put at a pretty low end of the list. So at the bottom of the CAP checklist on this page, there is a note saying that for melanoma in situ, elements that assess the invasive components are not applicable and should not be reported. So we've had this kind of challenges in the past when protocols are used for multiple types of samples, because I'm really more concerned about the completion rates as scored by CCO, because, for example, once you put in no residual melanoma identified in our re-excision samples, all other paragraphs pertaining to invasive melanoma will be void. And so if one user is using the CAP checklist straight up, so you go through a lot of blank space, and then that could kind of induce errors in your entry. And for the middleware design, as I have not seen the latest that come out with my middleware usage, I don't know actually if the change is going to work. And the programming, of course, is that when you, say, put in situ melanoma as a diagnosis, then all the options for invasive melanoma will be automatically dropped or disappear from the checklist. So just as an illustration, and my next slide, and I don't know how many people are using these middleware and third-party templates. When they work, it's really very good because it helps with your completion rate. And if you go to the top right and you look at the button or the icon next to the green next unanswered, basically they program it so that you only have to answer the mandatory entries. So you click on the next required and they come up with all the options, and at the end of it, you'll be done. So that certainly helps with the completion rates, as I mentioned, but obviously the design has to be perfect to work, and so I'll have to wait and see for this one. Anyway, moving on. Maximum tumor thickness, again with the new comments, nothing new there, and we're probably used to the at least and millimeter square entry there when the tumor cells are seen right at the margin of the sample, for example. Anatomical level, the POX level now has and has been for a while with the plus signs that is non-mandatory, but I would still suggest using the POX level because once in a long while you could come into a situation where you have a PT1A clock 4, as in say the eyelid or genital skin, where it's pretty thin and atrophic. It should help in the discourse during, say, MCC for the management and how aggressive to treat these type of lesions, because I still think that a PT1 Class 4 lesion probably has a worse outcome than a PT1 Class 2 or 3. So I would suggest still kind of including it for the benefits of the patient. Ulceration, of course, we recognize the importance of ulceration right now as a poor prognostic sign, and a PT4B, for example, probably has a worse prognosis than a pathological stage 3A, i.e. non-ulcerated primary, but with micronodal metastasis. So it's something that we need to be attentive to. So next slide, please. Basically, a couple of examples. Top left, that's sometimes the kind of samples you get for a case of suspected melanoma, and you'll be happy that you actually make a diagnosis of melanoma and not basal cell carcinoma. So in this type of situation, you do the best you can and find a fragment that's best kind of embedded, orientated, and then give an approximate breast loss measurement with the qualification that tumor is present at the deep margin and is at least so many millimeters in measurement. I beg your pardon, I think earlier I mentioned millimeter square, which obviously this is not, is a breast loss measurement. Bottom left shows melanoma arising in a pre-existing nevus. We all have challenges trying to delineate where is the maximum tumor thickness and where we start from. If you have difficulty, I'm sure we all have difficulty. So again, we try to make the best of it, and we're not really mathematicians in the sense that a lesion of 0.76, for example, probably will be similar to a 0.84. So I wouldn't really personally fuss or waste a lot of time in trying to figure out the minutiae of differences, except obviously when the measurement falls on critical values like between 0.9 and 1.1, or between 1 and 2, or 2 and 4 kind of watershed areas, then I suppose we need to be more attentive so that we don't upstage or downstage a patient. Bottom right, we know that we're not going to measure breast loads or maximum tumor thickness from tumor clusters that extends along the follicular or adnexal epithelium and tumor in the adventitial dermis. And top right basically is an ulcerated lesion reminding us that we need to have a total absence and loss of the epidermis and with the basal membrane, and then the presence of inflammatory exudates, and we should also see some degree of epidermal atrophy or reactive change so that we know that this is not from trauma like biopsy. So moving on with the checklist, the peripheral margin, nothing has changed there. And for the long form, the measurements must be included. The red sign, again, is really for the biopsy case summary. Good to see that for specifying location they have if possible, because at times if the clinicians don't mark it, it will be difficult to do it. And nice to see that the specified location has been removed previously, and I thought I remember that it was also in deep margin, and all I could write there is usually the center of the sample, and that's all. So very positive changes in the latest 3.4 version, and really shows that they pay attention to sometimes the feedbacks that we have for them. So next slide is on the mitotic rates from high power fields changed to millimeter squared, and we've had it for a number of years, and the change, I believe, was from the 6th to the 7th edition. Easier to do, in my opinion. All you have to do, of course, don't need me to remind you, is to figure out the area of your high power fields. Myself, for example, I like to use the 10 times objective to my 10 times eyepiece to make it a times 100 magnification for my mitoses. I know that my high power field is 0.245 millimeters square, so I scan for 4 of my fields, my times 100 fields, and I should have the mitotic rate. So I hope I made myself clear. And then the methodology, of course, you go to the hotspot first. And sometimes thin melanomas, especially those with cytological, a lot of cytological atypia, they tend to have quite frequent mitoses. And the example I shown actually have 3 little mitoses on the melanoma that is less than 1 millimeter. So go to the hotspots first, figure out 4 fields, that is whatever your calculation is, and add it up to 1 square millimeters, and you have your entry. And dermal mitoses, as a reminder, again, light ulceration can move a PT1A lesion to a PT1B. It's significant because that actually will PT1B lesion has a 5 to 10% survival disadvantage when compared to a PT1A, and mentioned previously, ulcerated thick melanomas, i.e. a PT4B, actually has a very bad prognosis. Ulceration doesn't count when it affects a MIS or melanoma in situ, of course. So let's go to the next entry, which is the microsatellite causes. This is really a pictorial explanation of what a microsatellite is, and it is a nodule, a tumor nodule, separated from the main tumor by a distance of at least 0.3 millimeter. And the tumor nodule, the diameter should be more than 0.05 millimeter. Tumor nodules need to be within the reticular dermis or subcutaneous tissue, and should be really in the sections where you do your Brussels measurements. So I put my little scale there, and Brussels measurement, of course, is from the granular layer to the deepest portion, and the scale reads about 1.5 millimeters. So this tumor nodule at least is closer to 2 millimeters or so. So microsatellites, satellites are bad prognostic indicators, as we all know, and automatically an N2C lesion again slotted to a pathological 3B, and a survival rate according to conventional numbers will be 50% survival in 5 years. So that is significant. If I may move on to the next entry, which is the LVI, lymphovascular invasion. The neurovascular bundle tends to be usually a fertile hunting ground. So it's your finding of the LVI perineural invasion is proportional to the time you spend. But they are really features of more aggressive melanomas, and you can see that really tumor cells are within dermal lymphatic channels, and also I believe a couple of tumor cells in the nerve bundle on the left side of the slide. Again, the recurrent new comments being added to these titles. Next is the slide. Is the perineural invasion, which is common in desmoplastic neuroid type melanoma. And right slide, of course, is a higher magnification showing tumor cells right within those nerve fibers. And perineural invasion, of course, pertains to higher local recurrence risk. So moving on, tumor infiltrating lymphocytes with the plus sign, so not mandatory and applicable to invasive tumor only. The background slides is one in which I would personally score it as brisk. The lymphocytes tend to be hugging the bottom of the tumor cells and or actually infiltrating into the tumor nodule. The insert is the higher power showing the lymphocytes actually within the tumor cells, causing cytolysis, vacuolation of the cytoplasm, and tumor cell death. So the lymphocytes are potent, as we know, with this recent success from many from the immunotherapies, the immune checkpoint agents, and inflammation, usually TIL, heavy TIL, precedes tumor regression. So for tumor regression, it is really a progression from brisk inflammatory response. And my next slide, I think, show what regression is like. Liberation of the melanin from tumor cells result in many of the macrophages, and you could have what is called tumoral melanosis, as basically a accumulation, an aggregate of pigment-laden dermal melanophages as really the tombstone of a regressed melanoma. Lower bottom, of course, is a regressed melanoma with not a lot of pigment, and you see that fiber scarring that really looks like scar. I know that the cap party line is that melanoma, significant melanoma, 75%, carries with it a bad prognosis. But personally, I think the jury is still out, and there was a big meta-analysis of 14 studies in JAMA last year, studied over 10,000 patients, and those with significant histological evidence of regression actually has a 44% lower likelihood of positive sentinel node. So as I say, I think we just don't know how to look at these lymphocytes yet. We don't, back to my point about the success of some of the checkpoint inhibitor, immune checkpoint inhibitors, that perhaps we'll need some newer markers in helping us to look at the lymphocytes as well as the antigen presenting dendritic cells in these situations to actually know what's going on and at a molecular level. So the next feature is the growth phase, which really is superseded by the Brussels measurements. It's no longer a mandatory entry. And intuitively, of course, we know that radial growth, i.e. tumor cells restricted to the epidermal cell layers and the superficial papillodermis probably has less access to the dermal lymphatic channels and therefore a better prognosis than those with a vertical growth phase. Inserts, of course, is the typical pagetoid spread and micro-invasion of the papillary dermis, and of course, this will be your classic CLAP2 lesion. And I included the next slides to show what my kind of threshold for vertical growth phase, as defined by a distinct nodular tumor aggregate that is completely within the papillodermis, some stromal reaction, and this nodule has to be bigger than any of the junctional nests in the lesion there. So that's the definition of vertical growth phase. So I think we've done with most of the local regional histopathological features, and moving on to the lymph nodes in the long excision re-excision case summary. Nothing new there, except again the comments, and that this section now is omitted in the biopsy sample. I would again see the columns of plus signs on the size of the tumor, the nodal mats, extranodal, the location of the mats, as well as the extranodal involvement. I would suggest that, if possible, certainly enter those data and information, which, as I will show you later on, helps only in situation where there is debate whether to go on for further completion lymphadenectomy for some of these patients. And I've mentioned there that the NCCN certainly recommend the recording of the size and tumor location. So let's look at some examples of nodal mats. Next slide. And they're not difficult to really interpret, and melanoma sometimes come with their own special stains, as in the right, there's a very brown pigmented tumor that extends into the extranodal fat. Next slide, please. You can obviously, with the last update, we can diagnose it on the H&E, and we can diagnose it using the IHC. Left side is the marked one, a cleaner antibody that highlights mostly the tumor cells versus the S100 protein that stains up sometimes the dendritic cells in the lymph nodes. So it's a bit dirty in the sections. I don't like the HMB45, which Cap kind of mentioned, because really it's not a very sensitive, be it specific stain. So moving on to the next one. remember that we dropped the ITC. So if you're sure, if you can sure that you have a single tumor cell, be it on the H&E on the right, I think I see maybe 3 kind of epithelioid cells in the subcapsular lymphatic channel there, versus the MOTS1 staining of maybe 3 or 4 tumor cells. And if you can be sure that that's the melanoma or melanoma cells, then you have an N1. But as I mentioned previously, the size and locations do matter a bit because of really pretty sound and big studies in the past, and coming up with some the AS classification or the Rotterdam-DeWaal combination criteria, in which it says that nodal mets that are less than 0.1 millimeter and in subcapsular space really signifies only a 3% chance of finding positive non-sentinel nodes. So for some patients or some situations, really completion lymphadenectomy after ITC or small nodal mets is perhaps not indicated or even detrimental to patients, versus, of course, bigger mets, parenchymal, right into the parenchymal or extranodal extension in lymph nodes that carries 32 to 40% chance of having positive sentinel nodes. So I think we are done with the nodes, and if we can move on the next slide, please. Oh, one other slide. Back to the rule about IHC as a primary diagnosis. So at times you just have to be, and I'm sure we all are aware of this situation. Slides on the left, a picture on the left, shows positive cells, but in the capsular area. And of course, if you reference it to the H&E, these are nodal nevi. And so on the safe side, always compare it to the H&E. All right, we are done with the node for sure, and move on to the PT staging. Nothing new there, and I'm not going to waste much time except to point out that you can have YC for PTYC for clinical evidence post-treatment versus YP is it's pathological. And when you use the little R, make sure you're not confused with the big R that CAP also suggested for residual tumor. So nothing new there. And next slide. Highlighting the N2C stage, reminder, macrosatellites, different from microsatellites, which I define as aggregates of tumor that are visible clinically and but less than 2 centimeters. That's right, less than 2 centimeters from the main tumor, whereas in transit metastasis is aggregates of tumor more than 2 centimeters from the main tumor mass, both N2C and CAP thinks is best, and indeed prognostically they belong to pathological 3B. Next, nothing much new there for PM1, but reminder too that it is, pathologists only make comments and make the entry in the PM staging when we see it on the slide. So an example would be you have an excision of a melanoma of the arm, and then you have a lung wedge excision for metastasis, then so we can enter a PM1B, but otherwise we can ignore it. And really for the diligent practitioners, you can look up clinical labs sometimes. Serum lactic dehydrogenase, LDH, is still really a cheap and reliable prognostic test for these advanced stage patients. I believe that comes really to the end of the conventional protocol, and I should move on to the ancillary studies. I need to start by acknowledging the great help that Dr. Suzanne Cameron-Reed has given me and offered to me for the preparation of this presentation. I'm really, I know nothing about molecular pathology, and but Dr. Cameron-Reed was very kind, gave me a private tutorial on the biomarkers, as she is a contributing author to this template. The three questions I basically asked Dr. Cameron-Reed is, I want to know the rationale behind the design and how to use the template. The next question is, what do I have to know? Or what do I have to learn? Old docs really don't learn new tricks that well, so that really is one of my most important questions. And then my last question is, what do I have to do? Do I have to fill in this template? So I'm going to share some of the answers with you, and that's really my part on the biomarkers template. So going to the next slide, and this is really the next slide, please. The answer to my third question is, like, do I have to complete this protocol? One slide back, sorry. If you can go back to the previous slide. Thank you. Yeah, this is good. The paragraph says, completion of the template is the responsibility of the laboratory performing the biomarker testing and or providing the interpretation. I don't know how many molecular pathologists actually are in the attendance, but I believe majority of us as anatomical pathologists, surgical pathologists, we don't really do the molecular testing, so my message to you is really we don't have to worry about the entry of information on this template. On the other hand, we do really have to worry about understanding it and making some sense of it. I'll give it a try now by going to the next slide. And this is the template. Sorry for the small fonts because there are really a lot of alphabets and numbers, but the template actually lists the common mutations, and CAP for its 1.0.1 version included 3 proto-oncogenes that are known to be mutated in melanomas. They are the BRAF, the NRAS, and the KIT, or the c-KIT. And to me, the main story in melanoma is the BRAF. Also listed in the template is our collections of methodology and tests, and by listing, I suppose CAP really recognizes the validity of these tests. Also note that against all the entry fields are the plus signs, meaning none of these are compulsory. So according to Dr. Camori, the first attempt, version 1 of the biomarker template really is a platform to gather information, an environmental scan, basically wants to see, concentrate and consolidate data information of molecular testing in melanoma, gather it in one place so that it's easily accessible to the clinical management team. There are no standards yet, but I'm sure that standards are going to come, i.e. more consolidations of the gene mutants, perhaps new oncogenes added, and consolidation of methods as currently, for example, the COBAS 4800 under the BRAF, if you can make it out on your screen, the very first one, basically is a proprietary platform put out by Hoffman-LaRoche, and it is the platform used in the original successful clinical trial back in 2011 to validate, at the time, the complex, I guess, is under Plexicon, under PLX 4032, which evolved to become mirafenib, the BRAF inhibitor that is so successful. So COBAS, for example, is FDA approved, and soon followed by the THX-ID, which is another proprietary platform put out by BioMuriel in support of GSK, the GlaxoSmithKline BRAF inhibitor, the dabrafenib, which also now is FDA and Health Canada approved. So there are a bunch of these proprietary platforms versus the other more routine methodology like NSX or the Sanger sequencing. And so, as I mentioned, I know nothing of these testing methods, and these are the domains, molecular laboratories, and for them to figure it out. And I will do a little summary of what we really should know about these tests as surgical and anatomical pathologists later on. So, moving on the next slide, if I may. There is one update in June 2015 that is the 1.0.0.1, very minor, but I think as morphologists, surgical pathologists, we should be happy to see immunohistochemistry included in the comments, i.e. that if gene mutation is tested with more than one methods, i.e. the molecular methods versus IHC, that we should really, results should be made aware of in the comments, comment section of the protocol. So that means that if you can remember the story of, say, the estrogen receptor, started out many, many years ago as a biochemical assay. Surgical pathologist needs to go to the OR to get the fresh tissue for the biochemist and measurement in femtomoles and positive, negative. Two, currently the success with antibody against estrogen receptors, and we can do it on the slides. And the same story for HER2, and I imagine that many of these biomarkers sooner or later will be IHC tested, and becomes really the domains more of the surgical pathologist. So that's really just summary of minor changes to the biomarkers template. Next one, please. And courtesy of Dr. Camori, and this is really an answer, her answer to what I should know, or as a surgical pathologist should know about driver genes in melanoma. So in the interest of time and really scope of my presentation, I really just want to highlight BRAF as the main mutant genes that's important of the, in melanoma, and that is really related to the success of mirafinib, the BRAF inhibitor that is being used and approved by Health Canada. And as you can see, the map upstream RAS and upstream KITs, these are driver genes important in the MAP kinase. And the MAP kinase event, of course, is the process to drive cell differentiation, multiplications, and tumorogenesis. And this is true not only in melanoma, but in many tumors, especially. But happens that patients with melanoma, with advanced melanoma, actually do respond, at least partially and temporarily, to BRAF inhibitors. So for the next slide, as anatomical pathologists too, we should know a bit about the alphabet soups and the numbers that are being posted in the templates. And I will use this slide and the BRAF as an example to explain the letters and the numbers. Once you know about these letters and numbers, then you can easily figure out for the RAS gene and the KIT genes, and you understand the rest of the template. So bear with me a bit, and I hope I can do a decent job. And as a traditional surgical path, bringing up with classic cytogenetics, and focusing on the red circle now, the BRAF V600E C.1719 T more than A mutation. I want to know the location of the BRAF gene. So next click, please. It is the BRAF gene actually is in the chromosome number 7, the long arm Q, position 34. It spans 18 exon, but the most frequent mutation is in the exon 15. Exon, of course, is the usable coding in the genome to produce a protein. There are many ways to show the address of this gene. And the next click, please. Basically, some of the other references, depending on what map you use. So if you use the location, under location UCSC, the Santa Cruz University, California map will map it to chromosome 7, 140.72 to 140.92 megabytes. And that gives the size of the BRAF proto-oncogene gene, which is at least 190,000 base pairs. And some of these base pairs, of course, are not exons and protein producing. And so if you look at the messenger RNA sequence, it will be only 2478 base pair. And for the coding DNA out of the messenger RNA, that's what C stands for. The reference coordinate will be 1799 position. So the T stands for nucleotide thymine, and A stands for adenine nucleotides. That means a substitute. That means a single point mutation. And this is a missense mutation. That means that it translates to a change in the protein, i.e. one of the amino acids. Next click, please. The little funny wriggly worm, the diagram, shows a 3D molecule of the BRAF kinase, and this is the protein. So a change in the genetic coding actually affects one of the amino acids, which is in position 600. It started as 599, and I guess somebody miscounted, and later literatures become 600. And the V stands for valine, and you just have to look up your basic biochemistry to find all these little letters standing for different amino acids. And E, of course, is the glutamic acid. So V600E, the mutation is found in over 60% of melanoma, and in up to 90% of the BRAF mutation is V600E. I should have said that 60% of melanoma patients will have BRAF mutation, and 80% of these mutated BRAF is in the position of, it affects the protein V600E. So, next click, please, indicates how this mutation, genomic mutation, can show up in sequencings in which the little double letter on the upper part, the BRAF V600E/plus RAF will show up as an additional adenine nucleotide to the thymine nucleotide, signifying a substitution, and then translating to the change. So, going on, again, courtesy of Dr. Reed, the first very successful treatment of a 36-year-old patient with metastatic melanoma in Toronto notes the release of approval by Health Canada of Celboraf, the trade name for mirafinib, was February 2016. And this patient actually, for compassionate reason, was given a drug in 2011 December. And by February, and you can see on the right side, the lung fuse were cleared. And he was one of the lucky ones, and he is apparently still in remission with this BRAF inhibitor after 3 or 4 years, which I guess is unheard of previously in melanoma. So the success of BRAF inhibitor basically, as I mentioned, is the main narrative in melanoma patients with metastatic disease, and the inclusion of biomarkers really is trying to keep pace with advances in these targeted therapy. So next slide. As I mentioned, I won't go into the details of the NRAS or the kits, and I'm sure that you can figure it out easily yourself. And also, NRAS mutation signifies a more aggressive lesion usually. And NRAS and KIT mutation are mutually exclusive in patients with BRAF mutation. The story, and I think it's still a fair statement, a true statement at the moment, is that there is no effective anti-NRAS or anti-KIT treatments for these melanoma patients that show these type of mutations. Also, I should mention, and according to Dr. Reed, is of course for the anatomical pathologist, we should be attentive to sample requirements, i.e. that we need to select good samples, tumor cell reach sample for molecular testing. We all know that if we don't give good samples, we won't get good results, and that's a given. But many of these molecular testings really are very sensitive, and they can usually detect tumor mutations with less than 5%, or around 5% at least. But anyway, more is better, of course. We should know the gene that is to be tested. For example, there's no point testing BRAF, NRAS, KIT together, I guess. And we should learn about the sensitivity, specificity of these tests as well. But these usually are provided by the molecular labs. I would be remiss not to mention other molecular diagnostic tests in melanoma. At least you get the impression that it's only the three BRAF, NRAS, and KIT genes named that are found to be mutated in melanomas. There are many actually chromosomal abnormalities and CNV, like copy number variations, have been used in genomic comparative hybridization for diagnosis, for differentiation from, say, spitzoid tumor from spitzoid melanoma, for example. Also want to point out the genomic expression profile testing. This is like the breast oncotype, DX type of situation. 31 genes tested in melanoma in a commercial kit called the Decision DX-Melanoma, and they claimed that they can differentiate PT1A and PT2, that is the early melanoma cases, into class 1 and class 2. Class 2 has a higher percentage of lymph nodal metastasis. So there are many other testing outside, which are, again, really outside the scope of this talk. So in summary, next slide. I've gone through the latest 3.4 version of melanoma protocol. I've gone through the recommended biomarkers, templates. I've mentioned the benefits of biopsy case summary that can be standalone, and I've mentioned other minor modifications. Next one. I've, as I mentioned, the cap version for the time being is really more a data collection and expect standards to follow, and obviously further updates. I'd like to point out the AGCC 8th edition is almost ready to come out. And lastly, as surgical pathologists, anatomical pathologists, and morphologists, we should be attentive to advances in morphogenomics and morphoproteomics. So I think I ran a bit over time, but thank you very much for your attendance, for your attentions. I want to thank Dr. Pollitt for hosting the talk, and Shireen and Goran for helping with the slides, and thank you very much.
Thank you, Dr. Shum, for an excellent presentation today. We do have a couple of questions for you, so I will do my best for us to get through them all. So our first question for you, and thank you to everyone who has submitted a question, is from Dr. Amir Samani, and Dr. Samani asks, sometimes deeper cuts show continuity of microsatellite with main lesion. Do you recommend multiple deepers before diagnoses of microsatellite?
Well, the CAP's recommendation is we should not really do extra or exhaustive sectioning, at least that kind of serial sectioning should skew some of our observations. So I would just do the usual sections and make an interpretation. That's my personal opinion.
Thank you. And Dr. Samani has another question. What criteria do you use to differentiate a dysplastic nevus from melanoma in situ, especially at tips and peripheral margins of an invasive melanoma?
Sorry, if you could repeat the first part of the question again, please.
What criteria do you use to differentiate a dysplastic nevus from melanoma in situ, especially at tips and peripheral margins of an invasive melanoma?
Good question. Difficult to answer in a short time. My opinion is that a high-grade dysplastic nevus is the same as in situ melanoma. I know that there are so many controversies out there. Some people don't even classify a grade dysplastic nevus, but for me, if you think it's high-grade dysplasia, I would not use the term dysplastic nevus. At least there is confusion clinically. I would use the term melanoma in situ, whereas the Cox type of dysplastic nevus usually don't show that degree of architectural or cytological atypia that would be that could be confused with melanoma in situ.
Thank you. Our next question comes from Dr. Raymond Wang, and he asks, does the presence of mitosis in the dermal nest makes it vertical phase?
The answer is probably no, in a sense that vertical growth is defined by the conventional criteria, as I mentioned, the demonstration of dermal metastasis in a melanocyte in a non-vertical growth phase will be really unusual and maybe a hypothetical question. I have to think about it, but I would say it's no.
Okay. And Dr. Mong has another question. How do you classify when you find melanoma cells in the lymphatic vessels in the capsule of the lymph node? Is this positive or negative lymph node?
Inside the capsule of a lymph node with melanoma cells will be N1 according to current criteria. It would not be an in-transit metastasis as they have arrived.
Okay, thank you. Our next question comes from Dr. Dae-Tong Kim, and Dr. Kim asks, this is how does one distinguish between a benign nodal nevus of a lymph node versus a metastatic focus of melanoma?
I guess location, cytological atypia, probably. It's an H&E differentiation. Location is important, although I've seen nodal nevi dipping into the parenchyma.
Okay, thank you. Our next question comes from Dr. Ken Newell. And Dr. Newell asks, how do you measure a superficial malignant melanoma with a central vertical growth phase and shouldered in situ SSM component?
Measure the, I assume it's talking about breast loss measurements. And so it will be the granular layer, if it's not ulcerated, to the deepest part of the vertical growth. Of course, a superficial melanoma can have vertical growth, so it's really to the deepest part of the tumor, independent of adnexal epithelium.
Okay, thank you. Our next question comes from Dr. Myrna Chababi. Could you please comment on the use of SOX10, and benefits and caveats in sentinel lymph node biopsy?
Personally, I've not used it. I'm sure that it will be just probably as useful as the MART1, but it's not specified by the CAP, which suggested MART1 and HMB45 only.
Okay, thank you. Our next question comes from Dr. Claude Laplante, and Dr. Laplante asks, do you accept frozen sections for sentinel lymph nodes?
Do not, no.
Okay. And Dr. Laplante has the next question. Can you please comment on the benefits of the use of BRAF by IHC? BRAF by IHC.
Well, successful trial and validation, I believe 2013 even, the Ventana has the antibody. I'll have to look up the actual reference. 97 to 98% correlation. So it's probably usable, and that kind of explains why the CAP included the new comments that if IHC is used, it should be mentioned in the comment section, and I would think there will be a lot of validations, and certainly validation within your lab, validation in contrast compared to acceptable molecular testing before use.
Thank you. And our final question comes from Dr. Ken Newell, and Dr. Newell asks, what protocol do you suggest for assessing sentinel lymph nodes in terms of levels and IHC?
Small node, lymph nodes less than 2 centimeters, you just put it all through. 2 millimeter serial sections, H&E sections with blanks. You know, I'm pretty traditional. I look at the H&E section first before ordering the IHC.
Okay, thank you very much. That comes to our question period now comes to an end. Dr. Pollock, if you could please give our closing remarks.
Thanks very much. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I'd like to thank Dr. Shum for an excellent and comprehensive presentation today. As a reminder, both the live and recorded presentations are eligible for continuing education credits. In order to request your certificate of participation, please provide your name and email address by following the link included in the session notice. At the same link, you will also find an optional session evaluation form which we encourage you to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions, and please see the session notes for more information. I'd like to bring your attention to the upcoming CAP checklist education sessions. In 2 weeks, on April 27th, we have Dr. Theo Vonderkos giving a presentation on the urinary bladder. And on May 11th, Dr. Gino Summers will be presenting on pediatric rhabdomyosarcoma. Thank you for your participation, and thanks again to Dr. Shum.
Goodbye, everyone.
Bye.